All right, let's talk about some of the surgical problems of the colon. We'll talk about colonic neoplasia, both polyps and cancer. I addressed both of these in the medical section, in the GI section, but these are also surgical problems, so we'll talk about it here. We'll also talk about the diverticular diseases of the colon, more known as diverticulosis, and the major complications from that are diverticular bleeding and diverticulitis. I talk about diverticular bleeding in the matachesia lecture, just because this is more of a GI bleed problem, and so if you want to get more information on that, you should tune into that lecture. I'm not going to talk about it much here. I will talk about diverticulitis, though. It's another one of the big complications of diverticulosis. We'll also talk about toxic megacolon, which is a big complication of ulcerative colitis, and then sigmoid volvulus, which is a cause of obstruction. So colon polyps happen to pretty much everybody at some point in their life, and the incidence of polyps really start to take off at about age 50. And so it's for this reason that we start doing surveillance colonoscopy in everybody starting at around age 50, at the most age 50. In some patients we start even earlier than that, and I'll talk about why in a little bit. Now, it takes about 10 years for a pre-malignant polyp, and not all polyps are going to turn into cancer, but if the polyp is indeed a polyp that will become colon cancer, it takes 10 years for it to actually become colon cancer. And so we generally do every 10 years screening for patients. Now, there are certain things that may make us want to do start doing surveillance on a patient earlier, so maybe start at age 40 rather than start at age 50. And there are some things that also might make us want to do surveillance more frequently. Now, I talk about this more in the medical section where I talk about surveillance, colonoscopy surveillance, but I will talk about some of the things here that play into that. So if the patient has a history of certain types of polyps, the types of polyps that can possibly be malignant or turn into colon cancer, then those patients we may do surveillance more often. If they have colon diseases, so namely inflammatory bowel disease, Crohn's disease, and ulcerative colitis, we certainly are going to want to do surveillance more frequently and probably earlier on those patients. If they have a family history of premature colon cancer, we definitely do surveillance at a younger age, start at a younger age for those patients. And then if a patient has personal history of past colon cancer or frequent polyps, or if they've got some of the polyposis syndromes, which I'll talk about, then that's going to indicate a more frequent and possibly younger surveillance. So a lot can be predicted, as you've probably gathered, about a polyp based on its appearance and characteristics. And by characteristics, I mean histologic characteristics. So some of these things are really important to know, and for the USMLE, I would say these three here, not so much atypia, because that's something that's a little bit more that you would see on a step 1 histology slide. But it's important to know that size plays a big role in whether or not that polyp is likely cancerous. So if it is less than 1 centimeter, you can almost for sure say that that polyp is non-malignant. 1% chance or less of being malignant. In between 1 and 2 centimeters, it's about 10%. So a pretty big jump from 1%. And then if it's more than 2 centimeters, and the bigger it gets, it's 50% or even more chance of being malignant. So this is a pretty good indicator. The gross appearance also kind of helps. So pedunculous appearance means on a stalk. If it's on a stalk, it's less likely to be malignant than if it's sessile. So sessile polyp kind of looks like a bush, doesn't really have a stalk that you can grab onto. The histologic type is also important. So hyperplastic polyps are the most common. Those are never malignant. Hamartomatous polyps can occur in some patients with some of those polyposis syndromes. Those themselves are generally never malignant. The polyps that tend to be malignant, these adenomatous polyps, are tubular, tubulovillus, and villus. So there's a tubular polyp, which is 5% likely to be malignant, and the villus polyp, which is 40% likely to be malignant. Obviously, the villus one is the one to be more concerned about. The way you can remember that is villus equals villainous. And then tubulovillus shows features of both. You will not be expected to know what those look like, but you will be expected to know that tubular, tubulovillus, and most of all villus carry malignant potential. And then atypia. More atypia means that it's obviously more likely to be malignant, thinking back to step 1. Okay, so colon polyps, there are these hereditary polyposis syndromes that are important to know about, and I talk about these in the medical section. Now there's the first one is Peutz-Jeghers syndrome, and this is an autosomal dominant disorder. So if you have a mom or a dad that's affected, you have a 50-50 chance of being affected. And what this is are hamartomas of the colon, and I'm not sure if they affect the rest of the GI tract, but they're hamartomas of the colon. So remember that particular histologic type. And the hamartomas themselves are not cancerous, but having Peutz-Jeghers syndrome puts you at increased likelihood of colon cancer. Also, something that you see with Peutz-Jeghers syndrome that you're going to be expected to know is buccal, labial, digital, and facial hyperpigmentation. Juvenile polyps are another syndrome of these colonic hamartomas. They can also have adenomas, so some of those pre-malignant polyps. These patients have a 10% or more lifetime risk of colon cancer, and this also is an autosomal dominant inheritance. And one of the things that can point you towards juvenile polyposis is GI bleeding in a child. Not a lot of reasons that a child should have GI bleeding. Juvenile polyposis is one of those reasons. These patients will get regular colonoscopies to survey for any kind of adenomas that may be premalignant. And then familial adenomatosis polyposis, FAP, is an easy one to diagnose. These are extremely diffuse colorectal adenomas. The diagnostic criteria is greater than 100, but obviously they're not going through and counting because it's generally quite obvious when you go in with a colonoscopy. It's the colon is just floored with adenomas. And so this is another thing that can cause GI bleeding in a child. And these patients will get prophylactic protocolectomies because they have a 100% chance of getting colon cancer. They'll all get colon cancer. So this also has autosomal dominant inheritance. Another way it can be diagnosed more accurately than colonoscopy would be the APC gene mutation test. And so in that case, you're actually testing for the error gene, but you can certainly diagnose it on colonoscopy as well, especially if the patient has the family history. Treatment here would be prophylactic protocolectomy that will eliminate the risk of getting cancer, colon cancer, and then there are some variants of FAP. So patients that have FAP who also have skin and mesodermal features, so osteomatosis, epidermoid cysts, and skin fibromas, that's called Gardner's syndrome. And then patients who have CNS features, and those CNS features would be primarily malignancies, that's called Turcotte's syndrome. Colon cancer. All right, so there are a lot of risk factors for colon cancer. Number one being your family history. So especially a primary relative, meaning a parent, a sibling, or a child who's had colon cancer, especially if they got that colon cancer at a young age. And also if you've had more than 2 or more relatives, that's also a strong history of colon cancer in your family. That's going to increase your likelihood of colon cancer. Ethnicity is important, so Ashkenazic Jews, I don't mean Jews here as in the religion you practice, I mean patients who are Jewish in background, Ashkenazic Jews. That's an Eastern European Jewish ethnicity. Inflammatory bowel disease puts you at higher risk for colon cancer just because of the chronic inflammation that's been going on there. Increases the cell turnover, and that increases your likelihood of colon cancer. Age, obviously greater than 50. That's why we start surveilling patients at 50. And then your diet, so patients who have a diet higher in fat and lower in fiber and who intake fewer fruits and vegetables and calcium, they have a higher risk of colon cancer, and so pretty much that's everybody in the U.S. And then obesity, which is a lot of people in the U.S., smoking, a lot of people in the U.S., and heavy alcohol use also increase your risk of colon cancer. So these are some of the list of things that increase your likelihood for colon cancer. The symptoms of the cancer itself are going to depend on the side that the tumor is on. So we prefer to detect colon cancer on a surveillance colonoscopy or hopefully detect it before it happens. However, some patients don't get their surveillance colonoscopies, and so these patients will present with symptoms of colon cancer. Those symptoms are going to depend on what side the tumor is on. So if it's on the right side, what you're going to get with any colon cancer is bleeding. And so if it's on the right side, if it's on the ascending colon side, that blood is going to sit around in the large intestine for a while, and so it can be degraded down into what would appear to be melena, or it could show as maroon stools, but it won't necessarily show as red blood or bright red blood. These patients can also have fatigue and pallor. That's going to be iron deficiency anemia just due to their chronic bleeding. And they may also have a right-sided abdominal mass, which would be the tumor itself. If it's on the left side, these patients, their symptoms are less so related to their bleeding, but more so related to their bowel habits. So they have a change in bowel habits. They can have constipation or diarrhea. They also tend to have a change in stool caliber, and that's because the tumor itself is blocking the stool from moving down into the rectum, and so it changes the thickness of the stool. They also have cramping abdominal pain, and that's because of the blockage and the occlusion. And then they can also have red blood per rectum, which we wouldn't see in right-sided masses. Both of them can have fatigue, weight loss, nausea, and vomiting. That's just related to cancer. So the best diagnostic test is going to be colonoscopy with biopsy. And remember that for patients who have any kind of GI bleeding, especially if it's presenting as melena or hematochezia, it's still important to rule out an upper GI source, so you can't forget that in your workup. Other tests that are warranted for patients who have suspected colon cancer are going to be a CBC and a CMP, because you're going to want to see how much blood loss there is. You're going to want to see if there's any electrolyte abnormalities. If the patient does get diagnosed with colon cancer, you're going to want to have a chest x-ray. You're going to want to get a CT, and this is to see if there's any spreading. And you'll also want to have CEA titers, carcinoembryonic antigen titers. This is the chemical that's secreted by colon cancer. I think it's a polypeptide or a carbohydrate or something. But anyhow, this is correlated with colon cancer. You're also going to be measuring this in patients that you've treated to see if the colon cancer is coming back. The treatment for colon cancer is segmental resection of the bowel. There are other procedures that are done. Radical resection of the bowel can be done, but at least you need to resect the bowel around the tumor, and then also the adjacent lymph nodes and mesentery. And from there you can stage the cancer. I'm not going to talk about staging here, but stage 1 and 2 colon cancer generally is treated with surgery alone. Stage 3 and 4 colon cancer is treated with adjunctive chemotherapy, and that's usually 5-fluorouracil, just like with esophageal cancer. All right, now this I also wanted to talk about, so hereditary non-polyposis colorectal cancer. This is something that is autosomal dominant. It's a genetic disease, but it can also be de novo, so it can be in a patient who has no family history of it, who's just gotten the mutation on their own. And this mutation is in about 3 to 5% of patients with colorectal cancer, so not a really large chunk. However, if you do have the mutation, you have an 80% lifetime risk of colon cancer, so it's a big deal if it's you. This is something that you should especially consider in a young patient who has colon cancer, or in a patient who has a strong family history of colon cancer. It may mean that they have the gene in their family. But especially consider it in a young patient. By young, I mean younger than age 50, younger than the age we would start normally surveilling. And so one of the things that you might consider in treatment plan for these patients would be genetic counseling, especially for their primary relatives. Primary relatives of patients who have colon cancer that's related to HNPCC, they should get colonoscopy every 1 to 2 years starting at age 20. And that's just because they have such a high risk of colon cancer. All right, diverticular diseases are related to just the presence of diverticula of the colon. And diverticula are themselves asymptomatic, except for when there are complications of the diverticula. And the diverticular complications are either bleeding or inflammation. Diverticula form because of deficient fiber, increased pressure in the large intestine. So this is primarily a Western problem. It's more likely to occur in patients whose diet is deficient in fiber. And 9 in 10 people in the U.S. do not get their daily recommended value of fiber, which is 20 to 25 grams per day. So this is a lot of patients, whether they have symptoms or not. The place where the diverticula form are the same places where the arterioles transverse the colon wall, and this also happens to be the weakest point of the colon, and so that's why the diverticula form there. If there's any place where the colon wall is going to bulge out, it's going to be in the weakest point. Now, it's important to know that the arterioles transverse here because this is why diverticular diseases put you at risk of bleeding. It's the sigmoid colon that's the most susceptible to diverticuli, whereas the rectum is often spared from diverticula. So sigmoid colon, descending colon, transverse colon, and ascending colon. That's just going in order of most likely to least likely to get diverticula. The main complications of diverticular disease, or diverticulosis, are diverticular bleeding, which is generally acute and massive bleeding, usually bright red blood. And then diverticulitis, which we're going to talk about here. This is infection and or rupture of a diverticulum. So diverticulitis is infection of a diverticulum, which occurs in patients with diverticular disease or diverticulosis, same thing. Don't confuse diverticulitis with diverticulosis. You can't do that. Diverticulitis is the infection of a diverticulum, whereas diverticulosis is just the state of having diverticula, whether they're symptomatic or not. Oftentimes, diverticulitis is the heralding sign of diverticular disease. So remember that patients who have diverticula, they don't have symptoms otherwise. Diverticulitis is usually the first thing that's going to show you that they have diverticulitis, that they have diverticulosis, rather. Okay, the symptoms of diverticulitis include left lower quadrant pain. It's one of the very few things that can cause left lower quadrant pain. Fever and chills, That's just because of the septic process that's going on. Nausea, vomiting, abdominal or pelvic mass. If it ruptures, it can cause generalized peritonitis. Because you have inflammation here in the colon, you can have signs of fistula formation, and usually the fistula will form to the urinary tract. And that would be pneumaturia, which is air going into the urinary tract, or fecaluria, which is fecal matter going into the urinary tract. So some of the things that a patient may say that they have is that when they urinate, it's frothy, bubbly, that's the pneumaturia, or that it's a feculent smell, that would be the fecaluria. Labs that you should have for patients with suspected diverticulitis, of course, CBC and CMP. You want to know if there's an elevated white count, as there should be in diverticulitis. Blood cultures are also going to be important, just because you're going to be starting antibiotics, and any patient who's got a septic process going on, blood cultures is important to have, just so you pin down what the real problem is, what the bacteria is that's causing the problems. And then beta HCG is going to be important to get in any woman of reproductive age, because you're going to be giving her antibiotics. So if there is a fetus there, that's going to change your plan. Abdominal x-rays may be warranted as well, and that would be in certain patients who are at risk for toxic megacolon, so particularly the patients with ulcerative colitis or Crohn's disease, because we want to rule out toxic megacolon. Toxic megacolon can be kind of similar to this in presentation, especially if it's not your stereotypic presentation of diverticulitis. For diagnosis, generally we make this diagnosis clinically, especially if there's a history of diverticular disease, but otherwise the best diagnostic test is going to be CT with contrast. What you will never do, though, is a contrast enema or a colonoscopy. Remember that when there is diverticulitis, there's inflammation, and whenever there's inflammation, there's friability of the tissue. And inflamed or friable tissue is weak. And so we don't want to be pushing fluid in there or pushing a probe in there, because you can cause rupture. And rupture would complicate the situation. So the treatment is going to be NPO, which means that we're not going to be having them eating anything. We want to usually do NG suction to get anything that's in their stomach out. We want to reduce anything that's going to be heading to the large intestine. We'll also put them on IV fluids, as we would always do, as long as any patient is NPO. But most importantly, we're going to have them on broad-spectrum antibiotics, which are going to especially cover the gram-negative bugs and the anaerobes. So there's lots of right answers for this, of what you can use, but traditionally what's used is ampicillin and gentamicin to cover the gram-negatives, and metronidazole to cover the anaerobes. Okay, so the complications from diverticulitis, and we usually hope that there's not a complication, and most of the time there isn't, but sometimes there can be. So intra-abdominal abscess, that's going to require drainage with CT guidance. And so intra-abdominal abscess will usually be suspected if the patient has a continued fever or if they have a palpable mass, but usually we're going to have a CT done on the patient at some point during their or before their release. And then a purulent or feculent peritonitis. So anytime you have peritonitis, the stereotypic signs are going to be guarding and rebound tenderness. If indeed they do have guarding or rebound tenderness, these patients are going to need laparotomy, and you'll need to do segmental resection and colostomy, since the bowel is perforated. And another important thing, that each bout of diverticulitis that a patient has, it increases their risk of another bout. So when a patient has had diverticulitis once, their chance of getting it again in their life is 10%. If they've had it twice, their chance of getting it again is 30%, and so on. Okay, toxic megacolon. This is a big emergency. Now, this can happen in pretty much anybody. However, you should be most suspicious in the patient who has ulcerative colitis, who suddenly presents with abdominal pain and appears really toxic. And that's totally different from their regular flares. So you should know that patients with ulcerative colitis and Crohn's disease, they can get flares of their disease where they've got exacerbation of symptoms, maybe diarrhea, blood in the diarrhea, abdominal pain. But generally, those patients are not going to be toxic appearing. They may run a fever, but they're not going to have bacteria in their blood. They're not going to have altered mental status. They're not going to have hypotension. So there's a big difference. These patients will appear much sicker than a regular IBD flare. Now, I said this primarily happens in ulcerative colitis, and it does. 75% of cases are in patients with ulcerative colitis. And then there are a certain percentage that happen in Crohn's as well. Other things that put you at risk, particularly in the U.S., are ischemic colitis and then pseudomembranous colitis, which, remember, is your antibiotic-associated diarrhea. So the symptoms here are acute abdominal pain, distension, and especially the toxic features, which are hypotension, altered mental status, fever, and so forth. Peritonitis can be found in toxic megacolon, and that's, remember, the rebound tenderness and rigidity. The best initial step, absolutely necessary anytime you think that the patient may have toxic megacolon, is going to be an abdominal x-ray. And I would actually say that any patient with ulcerative colitis who comes in with abdominal pain and has a fever should get an abdominal x-ray just to rule this out, because this is very, very deadly. So the best initial diagnostic step is going to be an abdominal x-ray. The diagnosis, however, is made on clinical criteria as well as radiographic evidence. So these three things need to be present. Radiographic evidence of colonic dilatation. That's because it's a megacolon, so there's going to be colonic dilatation. You need to have 3 or more of the following: fever, tachycardia, increased white blood cells, or anemia, and then at least one of these: dehydration, altered mental status, electrolyte abnormalities, and hypotension. And with that, you make the immediate diagnosis of toxic megacolon. However, on abdominal x-ray, in a lot of cases, it's going to be abundantly clear that the patient has toxic megacolon, and you're not going to waste any time waiting for those labs to get back. So the treatment is ABCs. A lot of these patients come in, they're dehydrated, they're hypotensive, they have electrolyte abnormalities, so you're going to get them replenished with fluid and correct any existing electrolyte abnormalities. These patients need to be on broad-spectrum antibiotics because they may have a perforation or they're at serious risk of perforation. So the best broad-spectrum antibiotics, the ones I see used most frequently, especially in lower GI problems, are the ones that cover your gram-negatives and your anaerobes. So ampicillin, gentamicin, and metronidazole generally gives you pretty good coverage. IV corticosteroids are also given. I'm not really sure why, but that's in the that's just in the guidelines. These patients also, of course, are going to be NPO, just because you don't want anything going into the colon. You'll get serial abdominal x-rays on these patients to monitor the dilatation. That's going to play a role in whether or not we ultimately do surgery. And we're going to want to avoid pain meds. Even though these patients are oftentimes in a lot of abdominal pains, remember, what is one of the things that pain meds do? They slow down movement of the colon, and we don't want that. These patients have megacolon, and if we slow down movement of the colon, it's going to worsen that. So these patients should, of course, be admitted to an intensive care unit for observation, particularly a surgical intensive care unit if your institution has one. You're not necessarily going to do surgery on all of these patients. You're going to observe them. And what you're observing primarily is their status and also the toxicity, if their toxicity improves. You're also going to be looking at those serial abdominal x-rays. So the general rules are, if there's no improvement within 3 days, then you'll do protocolectomy. If there's worsening toxicity, if their altered mental status doesn't change, if they have problems with hypotension, then you're going to do protocolectomy. If there's clinical or radiographic evidence of perforation, absolutely you're going to do protocolectomy, and if there's hemorrhage. The survival rate, if it's non-perforated, is 96%. So even though this is an emergency, it's got a good survival rate as long as it's being treated. If, however, it perforates, that drops down to 80%. So on abdominal x-ray, the things that you're going to look for are a transverse colon, generally dilated to at least 6 centimeters, and then a thickening of the bowel wall, and what that is edema of the bowel wall. And it can usually be seen as what's called a thumbprinting sign, or pseudopolyps. Okay, so this is the thumbprinting sign. So what you have here are the haustra of the intestine, and they're I don't know if you'd I guess they'd be inflamed, but it's mostly, I think, edema that's causing this. And so there's this thickening here, and so it looks like thumbprints. Here's another one. This one kind of has those pseudopolyps too. So those thumbprints are on the sides, and then the quote-unquote pseudopolyps are in the middle here. So here's your thumbprints and your pseudopolyps. And then here's some more thumbprints. Now this would be pneumoperitoneum. So chest x-rays are a little bit better to look for perforation because you're looking for air below the diaphragm wall. So chest x-rays, serial chest x-rays may be another thing that you'll want to have on your order list. So here's free air beneath the diaphragm. And here's another one. Okay, sigmoid volvulus. So sigmoid volvulus is torsion of the sigmoid colon along the axis of its mesentery, and the risk of this increases with chronic constipation because the sigmoid becomes heavier, and that allows for more torsion, for more rotation on the axis. So volvulus, remember, V-O-L-V, the word where that comes from, is the same word we get the word revolve, like to revolve around something. So volvulus just means rotation. This is particularly a disease of the elderly, the bedridden, the institutionalized, basically patients who don't get a lot of healthcare attention, maybe living on their own, maybe in a less than optimal circumstance for their care. So look for it, especially in those people. Symptoms. This is more of a subacute disease than what you would see in something like toxic megacolon. So this is more of a cramping or colicky abdominal pain that comes and goes. There's abdominal distension, invariably. Constipation and obstipation are usually noted as well. So the difference, constipation means that you're not passing stool, whereas obstipation is the feeling of needing to defecate but not being able to. So they're similar, but they're not quite the same. And these are all progressive. Nausea and vomiting may also be present as well. And nausea and vomiting doesn't really tell you anything, but what it may tell you is that there's a lot of pain. It can also tell you that there's a progressive obstruction. Some notable complications that can come out of this. So anytime that you've got a volvulus, you can get ischemia because the arteries can cut themselves off. So you can get bowel ischemia and gangrene, and what this would wind up becoming is a constant abdominal pain. You'd see toxic features. You basically see what you would see in your typical intestinal ischemia. Perforation is another problem, and this would be your peritoneal signs, so rebound, tenderness, and guarding. For diagnosis, the best initial step here is going to be an abdominal x-ray. So the abdominal x-ray doesn't come into play in a lot of things, but toxic megacolon and sigmoid volvulus are two things where it really does. Other tests that you should get include CMP and CBC. We're looking for inflammation, possible things that may point us to complications. Other things that you can do are a barium contrast enema, but there are there's some caveats to this. You can only do a barium contrast enema as long as the patient doesn't show any signs of peritonitis. So no rebound tenderness or guarding. If they have any of that, no barium contrast enema. We're better off just getting the abdominal X-ray. For treatment, most patients can be treated with endoscopic decompression, and that's going to actually also derotate the bowel. However, if the patient has complications, primarily if they've got the toxic features or if they've got rebound tenderness or guarding, then they're going to need laparotomy. Okay, so the first thing I want to show you on the abdominal X-ray is the coffee bean sign. So a lot of people don't know what a coffee bean looks like. This is what a coffee bean looks like. Okay, so here is sigmoid volvulus, and this very much looks like a coffee bean. And what this is your sigmoid colon, and it's literally that big. So you can't even see the rest of your colon. It's just your sigmoid colon, that big. Here's another one, and another one. Okay, the other sign that you see is your bird of prey sign. So a lot of people don't know what a bird of prey looks like. I didn't know either, so I had to look it up. And so here's a picture of a bird of prey. And it really does look like a bird of prey. So you would see the bird of prey sign if you were to do a barium enema. And remember, you don't have to do a barium enema, but you would do it you could do it in a patient that doesn't show signs of peritonitis. So here you did the barium enema. You can see obviously a very distended sigmoid, and then this sudden tapering off. And what that is where the obstruction is. And this is the bird of prey sign. You can also see your coffee bean sign right here. And then here's another bird of prey sign right here. There's the beak. And there's the sigmoid. And that's it.